Hi, I'm Bob Roth, managing partner and co-founder of Cypress Home Care Solutions. Since 1994, we've been helping older adults in the Phoenix community age gracefully and safely in the place they call home. Since 2014, I've been bringing you Health Futures, Taking Stock in You, a show dedicated to helping you live a longer, healthier, and happier life. Be sure to subscribe, rate, and review this podcast, and enjoy the show.
Welcome back to Health Futures. And today I got a special guest here with me. It's been 10 years ago since this guest predicted many of the trends that we're living today, from the growth of home-based care to value-based reimbursement and healthcare consolidation. Since then, he's interviewed hundreds of healthcare leaders, advised health systems, pharmaceutical companies, venture capital firms and investors, and built one of the country's premier healthcare intelligence companies. Joining me today is my friend Johnny Mack, John Marchica, CEO of Darwin Research Group and host of nationally recognized Healthcare Rounds podcast. Welcome to Health Futures.
Bob, thank you for having me. I really appreciate it. It's so good to see you. You know, it's been a few years, but it's so good.
It's been quite a few years. But 10 years since you've been on my show.
Exactly.
2016. So why don't you catch us up a little bit? John, it's been 10 years, and I think our conversation in 2016, would probably surprise you, or surprise certainly our listeners, where we are today. So tell us what's really been going on in the last 10 years.
Well, there's this thing called COVID.
Yeah, well, we're going to talk a little bit about COVID.
That interrupted things. Look, from our perspective at Darwin Research Group, we're always looking for the trends, right? And we're trying to, as the famous thing is that a Gretzky saying, right? Skate to the puck. Yeah. We're trying to see not just where are we today, but where is healthcare going? And that's, the $1 trillion question, right? I mean, yeah. It's a big question. But over the last 10 years, what I would say is, if we just take COVID out of the equation, I think that what was predicted, what we had hoped to happen, I'm trying to keep this not so wonky for your audience, yeah. But that we would be getting more value out of healthcare. I think it's that promise has not been fulfilled whatsoever. And when I say healthcare, I'm thinking of healthcare in the United States. It's not without effort. It's not without trying new payment models. It's not without introduction of new technologies. I'm sure we're going to talk about AI as well. But the reality is that the benefits have been pretty incremental that we've seen. Nipping at the margins of better care in some places, nipping at the margins of better cost structures, right? But, now, depending on whose estimate that you look at, is 40% of Americans have medical debt.
40% have medical debt.
Medical debt.
Yeah.
Rise in, let's say, Medicare Advantage plans, you would think that would help with the quality of care. So far, that hasn't proven itself to be true. Amazon, still in the game. Walmart, not in the game. So a bunch of big players, right? Big players.
10 years ago, they were.
They were. And so, a lot of promises unfulfilled is one way that I would state it. And I've got some positive things too.
Yeah, well, we're going to talk about them. So, I appreciate that summary of these last 10 years, because we're going to do a deeper dive. But, for our listeners, and for me too, Darwin Research Group has grown tremendously in 10 years. I mean, yes. I did my homework, and I actually looked at your website. I was blown away by the amount of staff that you have and the work that you're doing today. So tell us about what Darwin Research Group is all about, and what is it you guys actually do?
So before I get to that, what I want to tell people is how I met you.
Okay, let's go.
Even years before that, appearing on the show. And I was just getting started, and you may even forget this, Bob, because we've become good friends since then. But I had an analysis of the home care market. And that was a report. You remember how thick that was? And I gave you a copy of it.
Well, I hate to tell you this, but I just over the weekend purged And I let those reports go. I was like, these are like 12 years old. I don't need them anymore. Actually, they're like 12 or 13 years old. They were a long time ago.
Well, that's indicative of, kind of goes back to your tenure question.
Yeah.
Good. I'm glad you threw it out, because so much of that report is irrelevant. If you look at all of those big home health care companies and some home care companies,
Oh, yeah.
where are they?
Yeah.
They're gone. They've
gone.
been gobbled up. They've been, private equity has come in some cases other health systems have bought it. But in any event, so you and I met and through an introduction of through a friend, because I really wanted your sense of, hey, this is a new business that I have going. I want to be in this market intelligence world. You're an expert in home care. What do you think? And I'm trying to think of what advice you gave me at that time. It was probably something like, boy, this thing is really long.
Right. Well, I think one of the things I had to do was educate you and certainly many people out there in our community the difference between home health and home care.
Yes.
And how really different they are. And, home health is more episodic.
Yes.
And it's a visit, and it's kind of like your cable guy, you're given a time range and when they'll be there. It could be a nurse, it could be an occupational therapist, could be a physical therapist, could be a speech therapist, wound care specialist, a CNA to help with a bath or something like that. But home care is so different. It's so, concierge, if you would. And, I have a saying in my office says, and I use Vince Lombardi's quote, and that is, if you're not 10 minutes early, you're 20 minutes late, because you're expected to be on time, because most of the fees for the services that we perform are privately paid.
Yeah. And so absolutely essential. But going back to that time, I remember you giving me that distinction, and also something I still use to this day. It's not home care. It's in-home personal services. It's in-home care services. It's using this kind of, because people, they just get confused and they say, oh, it's care in the home, but there are different purposes, different reasons.
Or they call it non-medical,
or
they call it non-clinical, or they call it non-skilled.
They
tell the world what it's not,
right?
But they don't tell it what it is.
So important to make that distinction.
I've evolved since that time, and it's in-home supportive care.
In-home supportive care.
In-home supportive care. That's what we do.
Good.
We support those people in the home to be able to stay independent as long as possible. But thank you for remembering that.
Yeah. So,
That's great.
so going back in time and thinking about those initial days, I didn't have any employees. It was just me. And I said, Bob, please give me some advice here. One of the things that I found was, as we started to build a client base, that it was important to take a broader look at what was going on in healthcare. In order for us to advise, let's say, a pharma company or work with a health system, we had to look what was going on in all markets, in all ways that care is being delivered, how it was being paid for. And that was kind of where I got into very early on, really focusing on what we call value-based care, or extracting more value from the amount of money that we spend on healthcare, right? Different ways of doing that. And so in that time frame today, we're looking at something like 600 health systems across the country, and that also includes big physician groups, cancer centers. And we do our work primarily on the manufacturing side of things, to advise them on how to deal with this complex world of healthcare from a manufacturer perspective or from a care delivery perspective. So what's a treat about today is, I know your audience is much bigger, much more general in terms of people who want to understand healthcare, and to see if some of these concepts and some of these learnings that I've had over the years, and especially recently, how I can help make that resonate for your audience.
I appreciate that. And, it's interesting because when you and I met was basically right after the Affordable Care Act went into place.
That's right.
And these ACOs had been created. And just for our listeners and viewers, Johnny Mack and I, we went on tour. I mean,
we did.
We actually co-presented at national conferences, really talking about a lot of the work that Darwin Research Group does, and really understanding what an ACO is. And an ACO is an accountable care organization, but they were all brand new at the time.
Yeah.
And, people didn't know, and they wanted to know how they could prosper and grow their businesses and be a preferred partner in these ACO organizations.
Funny you should bring up ACOs. So on my podcast, on Healthcare Rounds, excuse me, over the last several months, so thematically, that podcast is about getting more value for the dollar. It's really pitched at healthcare executives. People are in the mix of either providing healthcare services or providing products and services, right? And so that's the general theme. But over the last few months, I've been interviewing CEOs, CTOs, academics, all around kind of asking the question, where are we with healthcare? Where are we with value-based care, that term again? And it just so happens, I think it dropped today, so I'm not sure when this episode...
This will probably drop next week, but okay. How do we find Healthcare Rounds?
We're on all major podcast platforms, on YouTube, Spotify, Apple, and all the rest.
Oh, I love it.
So healthcare, 2 words, Healthcare Rounds, and you'll find us. So in any event, the one that's dropping today is with Elliot Fisher, Dartmouth professor, one of the well-known guys coming out of Dartmouth, and he's the one who actually coined the term accountable care organization. And I flat out asked him, Elliot, Dr. Fisher, professor.
Elliot,
where
E.T. reference.
I got it. Where are we today? And his response was very disappointing. Very disappointed. The best we've been able to under that particular model, shave costs 1.5% to 2%. So nothing huge, no major improvements in quality. But I think what he would agree with where we are today is sort of a shift in the mindset of the healthcare organization, that it's not just about revenue. It's not just about profits. Although, if you don't have any revenue and you don't have any money left over at the end of the day, or if you're not for profit into your fund, right? They still make profits. And if you don't, that old saying, if you don't run a not-for-profit like a for-profit enterprise, you're probably not going to be around very long, right?
Exactly.
But instead of just being fixated on that, they think about how do we improve quality at the same time without spending a whole bunch more money? How do we, and this goes to the COVID, how do we have joy in work, quality of life in the workplace? How do we accomplish that? Because providers are leaving the industry left and right, doctors, support staff, nurses, right? We already had a shortage in these areas. How do we take care of, we say that we take care of the poor or the people who can't afford healthcare, but really, what can we do in these communities to improve healthcare for certain populations of people? These are concepts that were, when you and I first met, academic, really kind of in nature. Now it's really become like a mental map or a paradigm, if you will, the way that healthcare leaders think about advancing the quality of care in this country.
It's amazing how much has happened. And you're a professor from Dartmouth, Elliot
Fisher.
Elliot Fisher. I mean, I think he's spot on. I mean, I don't think, value-based turned out to be what we expected it to be. So I keep using the word 10 years, right? Because it's been 10 years since I've been on Health Futures with you. What prediction did you make back 10 years ago that you would say turned out to be remarkably accurate?
Accurate. What I would say is that at the time, and I don't know if I said it on your show, but that we would continue to see a proliferation of different attempts at trying to fix this problem in a bunch of different ways. And that has absolutely been the case. The second thing I would say is the technologies, and I remember it may have even been at one of those home health or home care conferences, NAMCP, right? It may have been at one of those.
The National Association of Home Care and Hospice,
NAC. One of those conferences.
Home Care 100?
One of them. Yeah, one of them.
One of them?
One of those. And seeing at the time kind of this emerging technologies that were happening to improve care in the home. And now the level of sophistication, I mean, it's absolutely not comparable. So I think in those ways, looking forward, I think I was pretty right. Where I was wrong...
That's where I was going next. So where were you wrong? Thank you.
Where I was wrong is not seeing, so maybe it's just by absence, really a lot of the vertical integration that's taken place in healthcare. I mean, United Healthcare has something like 100,000 docs. And biggest or one or two in terms of pharmacy benefit management. I mean, they own a lot of the elements of healthcare.
They bought two of the largest home healthcare companies,
exactly.
LHC and Amedisys.
And Amedisys, right, right. And so...
And they were publicly traded.
Yes.
So was United Healthcare. Crazy.
And I know they had to, at least in the Amedisys transaction, they had to dump a bunch of those locations to meet federal requirements. Yeah. But even still... so I think we would have shown more progress like Elliott. I think I would have been a little bit more optimistic and where I could have been wrong. The other thing is, I think I'll leave it at that, and we'll come back to. I'm sure I've got plenty of other things that I didn't see as well.
I got a few questions here. So John, it wasn't easy. It wasn't hard for me to pull this all together. So, healthcare has gone through a lot of changes. COVID, staffing shortages, inflation, consolidation, which we talked about, and AI. Which of these has permanently changed healthcare?
Well, I think if you ask the average person, the average healthcare person, I think there's some hope around AI and the change being permanent. And the question is, really, what is going to be ultimately the role of AI? And I keep hearing this recurring theme, and it's kind of going back to the interviews that I've had recently, where they say things like, really going to improve on the margins of the things that the tedious tasks that have to happen. We're really going to improve on our financial management of the organization. We're really going to improve on things like taking notes, virtual notes in a doctor's visit, and then being able to transcribe those and not just have the transcription, but do some predictive analytics around that, right? So I think there's a lot of excitement about that. But the one thing that they also say is you can't take the person, you can't take that physician relationship out of the mix or the caregiver mix out of the mix. There's something about that personal relationship that really needs to be there. And one of my hopes is, can AI reduce all the other clutter to make room for more of that personal interaction? I don't know last time that you saw a doc, Bob, but the visits just get shorter and shorter and shorter just because they've got to see more people in it.
Did I tell you I had a herniated disc? So yeah, I've seen a doc a few times, but I'm doing okay. Yeah. Thank you very much. But you're right. But you're right. I mean, it's amazing. And you hit the nail on the head, and we've talked about it here on Health Futures, is that healthcare, and especially home care, it's relational. It's not transactional.
Yes.
And we need to let the transactional stuff handle all the back office stuff and have physicians and caregivers, like you said, be very relational with the human interactions, because that's what we need. So, my curiosity is, we talked about AI, and yes, there's been a lot of hype. What's real? How is it changing, patient care today? How can we make it so it's not too technical? It's amazing. I mean, the world we live in today. I mean, you and I are roughly the same age, and we were fascinated when the Apple iPhone came out, and then it had Siri. But a lot of people didn't realize, but Siri was really the very early stages of AI and large language models, right? You could talk to it, and it would respond to you. But today, I mean, you hear about people having relationships with their AI agents, and AI agents are very real, and I see a lot of companies in my space making the mistake of having AI agents talk to clients and their families and their care personnel. Yeah. And there's a time and place for that, but the relational piece needs to be with humans.
Well, I'm curious from your perspective. So, and I learned this from you many, many years ago about the relationship and the home care provider. I mean, you want to see the same face, right? When you need that home care, you want to see, you feel comfort. You build relationships with that caregiver, right? But at some point, we have this sort of population problem where there aren't enough, and I'm sure we talked about this 10 years ago.
We can talk about the math.
Yeah, there aren't enough people
Yeah.
to manage the people, to care for the people who will need help. So how do you maintain that? How, from your perspective, Bob, how do you get, or how do you enable AI or other technologies so that you can still maintain that relationship? Is it virtual? Is it, because I don't think in many cases that works, because you need to have that touch.
I thought this was Health Futures, not Healthcare Rounds. You're asking me a question.
Well,
all right, but I'm going to answer it.
I could get one or two in there, Bob.
No, I'm going to answer it. I mean, and it's a great question. I mean, look, there is a staffing shortage. We all know that. And we need to be able to be smarter in how we deliver care. And in the old paradigm, we used to force 4 hours onto somebody, whether they liked it or not. That was all they were going to get. The cost of care in our world in the last 6-7 years is up 50%.
Wow.
And if you're going to get 24/7 care, it's $30,000 a month, $360,000 a year. So how do we do more with less? And the tech piece is a very important piece. The tech piece is really important for home care agencies like ours, where we can use a lot of technology in the back office to do redundant and repetitive tasks. But at the same time, we can be more relational, as I described, with our encounters with our caregivers and our clients and their families.
Sure.
But what we're doing now is we are using tech in the home. Matter of fact, on Monday, we're launching a new ambient monitoring company so that we can provide 24/7 care with technology. So the humans can be there during the day parts, right? We can make sure that, the client is taking their medications, eating their meals, getting ready for their appointments, maybe taking them to their appointments, all the ADL stuff that are done during the day parts. But we can leave them alone if they're independent enough to be left alone, and have monitoring in the home with predictive analytics, right? With AI, we can begin to create a baseline, and when we see changes, we can institute those measures to prevent a medical event from happening. So it's an exciting time. And I had a guest here a couple weeks ago that was on the show. I had a candidate for governor. I had Hugh Lytle here, but I had his father, Ben Lytle, who has a company called the ARC Project. Matter of fact, we're meeting later today, where he has created, through the ARC Project, alter egos, where you can put a lot of information into the computer, if you would, to the AI base, if you would, and you can have an alter ego answer a lot of those questions that you might want to get from that practitioner, but that practitioner isn't available, but you can speak with their alter ego.
So does it really, does it feel like that on the other end? Does it feel like, if I have Bob Roth's alter ego,
I have actually seen some demonstrations of it. I mean, it's really, really wild. I mean, we are like in a new realm. I mean, it's exciting time. It really is. To be able to get to people that you might not be able to get to, but you could get to them through their alter ego and be able to converse with them and get answers.
One step closer to Ray Kurzweil's singularity, right? We're just going to... We're going to live on forever because we're going to be up there in the cloud somewhere. We're going to upload, our personas to the cloud, and we're going to live forever. But in all seriousness, Bob, I think what you're getting to is sort of the second piece of that AI, and the second part of the benefits of where technology can take us. And that is so much of quote unquote care or healthcare happens when you're not in a doctor visit, when you don't have that caregiver there for you, right?
Right.
It's everything else that's going on in the absence of that. And so much of healthcare focuses on the episode, the doctor visit, the surgery, everything. But where things can go wrong, or where you can predict where things go wrong, that's all the in-between stuff that we're just, to date, we haven't been very good at that.
But one of the things we can do, I mean, look, we have these devices that we wear on our wrists, and people have things on their ring fingers, auras and whatnot.
Right.
I think at the end of the day, it's accountability, right? We need to be accountable, and a lot of ways we need to be held accountable. And I really believe through technology we'll be able to do that. I mean, the community health worker concept makes a lot of sense attached to a primary care, so that they can follow the patient, make sure they get their prescriptions filled, make sure they have their follow-up doctor's appointments, all of those things that need to happen. Because you and I both know, you said, have I been to a doctor recently?
Yeah.
I can't believe how much, and we could talk about this for a whole episode, about how much private equity has taken over these practices.
Yeah.
And I will tell you, they're mills. They're absolute mills. You go in there and you see signs for exam rooms, and they're like 16 or 18 rooms. You go into that room, you get a medical assistant comes in, takes your blood pressure, takes your temperature, whatever that is, and the doctor comes in, and the doctor gives you 7 minutes. Maybe it's 5 minutes.
Right.
And, if you're an older adult, you may have a list of things, or you might be forgetful, and then that doctor's left and you forgot to have that conversation with them. So I think really where I see things going is, for healthcare, for better health, is the accountability piece. We need to figure out how we can have consumers be more accountable for better health, to follow through and follow up on the orders that the physician or specialist has given to them.
Again, going back 10 years or even more, we started talking about accountable care organizations, and really without getting into all of the technical details of what that is, I talked about how we're trying to do all of these things at the same time, provide better care, and provide get better outcomes and keep costs down. And the one thing, it's still true today, but back in the day, that physicians who were really into this like kind of holistic way of looking at the patient would say, but I can't make my patient eat better. But I can't make my patient go and exercise. Or I can't mandate that they
Stop smoking.
Stop smoking.
Yeah.
Right. Now you can test. Anytime you go in to see a doctor, you can get a test. Or are you a smoker? You can do depression screening and all this kind of stuff. So I agree with you, Bob. I just wonder, how do we shift people to having that accountability? Is it a carrot model?
Oh, you
Is
and I.
Is it a stick model?
Oh, I love this conversation. I mean,
Let's
seriously.
go.
I mean, look, you work with a lot of insurance companies, and you work with pharmaceutical companies, and you work with a lot of them. And I would tell you, most practitioners and consumers of insurance products and services look at them as the bane of their existence, as the devil, as the devil. And, I think one of the ways would be, and don't get me wrong, I mean, we're having a conversation here, but, some of us, let's put it this way, were born with some, not so good genes, and we're predisposed to having maybe some really bad health outcomes.
Yes.
But some of us aren't. And I really believe that the premiums that are being paid today, and gosh, I mean, it's amazing how much it costs for my wife and I to have coverage. I think that we should pay less if we're healthier, and you should pay more if you're not. You talk about a carrot and stick. I mean,
right.
I think that in itself will encourage Americans to be healthier, because you're going to pay less if you're healthier. If if you score, and you know, there should be maybe a box that predisposed people with bad genes don't get penalized. You know, I don't know how to do that, but I mean, lifestyle is a big reason why people get type 2 diabetes. And you and I both know diabetes is probably, it has just grown so exponentially in the last 50 years. And so much of it is lifestyle.
Yes, certainly.
And diabetes affects every organ in your body, every single organ in your body. So imagine if you put something, and I just threw it out there, and we are totally going off script here, Johnny Mac. I just want you to know, but
that's fine.
But I really think that there, you know, you talk about a carrot and a stick. You know, let's put a carrot and a stick out there and encourage consumers to live better health.
I agree with you, 100%. The challenge is when we look back at disease management programs, right? For example, employer-based programs that were really popular in the 90s and the 2000s especially. They have been marginally successful at best. Every time that we try to do these kinds of interventions, you get marginal benefits, not great benefits. And so I think what is required, and I don't have the answer to this, a lot of people would say this, is sort of a societal shift, right? A societal shift towards
the blue zone.
You know,
we're right here in Scottsdale.
Blue zones.
Blue zones are a great way to educate people and get people active and activate them.
But it's the accountability piece that is really, really challenging. And where I struggle is in insurance markets, when you start, which is kind of like the idea behind the Affordable Care Act, or part of the idea behind that, is when you start cherry picking and excluding people from, let's say, a risk pool. Sorry, I don't want to bore everybody with this, insurance.
That's okay.
Then you end up having even more distorted markets. The idea is you want to have as many people in the pool as possible so that the healthy people can take care of the sicker people, right? Yeah. That's just the general concept. And I think most people in general would agree with that. I think also people would agree with exactly what we're talking about, which is, Bob, you're a pretty healthy guy, and you just underwent back surgery, right?
Yeah, thank you.
You've had other surgeries. I've had surgeries. We're both tennis players. We're both very active people, right? Especially for our age. So it'd be nice to know that we're not paying these incredible premiums that others are paying. But it also gets to, and Bob, I don't have an answer for this, but it also gets to the larger point of where we started. Everything is financial. Everything, there's a profit motive for all these organizations. There is you talked about private equity. Well, why do you see the signs pointing you in this direction? Why do you get 7-minute or 5-minute visits and all that? Because they're maximizing revenues, right?
100%.
And so...
And minimizing costs.
And then you say, well, look at the GLP-1s. Everybody likes to talk about GLP-1s, right? The other day, I was on an airplane ride. This is what I do when I'm bored. I look at lists of things, right? So this is a list of the top pharmaceuticals in the United States. And if you look at the Eli Lilly has 2 drugs, and Novo Nordisk has 2 drugs. And when you combine them, they're the exact same drug.
They're GLP-1
GLP-1s.
Okay.
Right? So there's one for diabetes, one for weight loss, but it's the exact same drug. It's just marketed with a different...
And they probably charge differently for both.
Well, that's what I'm getting to. So these GLP-1s, the jury is out. I'm not a doctor, so I'm not giving any advice here, right? You're not a doctor,
no.
Bob. But they have the potential for enormous benefits beyond just those things,
100%.
right?
Yeah.
But when you look at the list, if you combine these, the GLP-1s are the 2 top selling drugs in the United States. And if you combine Lilly and Novo Nordisk, it's over $70 billion a year in revenue.
Wow.
Right now, that's being spent. In fact, I'm aware... $70 billion. When Ozempic, which is Novo's product, when it took off, there were reports, I think in the Wall Street Journal, of it having an effect on the Danish economy because they're from Denmark, right? And so doing so well. So all of that is to say, we're certainly the profit motive here, in my opinion, and maybe I'm biased, but whatever investment went into these GLP-1s, I think the payoff is going to be enormous. But there was a financial incentive. There was a profit motive there, right? They're not creating drugs out of the goodness of their heart.
No.
Right? And just like not-for-profit health systems, if you don't have more money at the end of the day when you started, if you're not growing revenue, then you're not going to exist. So I think the tension, and this bears out one of the commonalities across the board from academics, industry people on all sides, say that the financing and of healthcare is absolutely our biggest problem in the U.S. And that relates to accountability, and it relates to the carrot and stick. And how do you treat patients who may not be as healthy? Maybe genetically we're identical, but they're eating Burger King. Sorry, Burger King. They're 5 times a week or whatever. They're eating fast food. They're smoking, and they're not exercising, and they're doing all of those things. So I don't mean to harp on it, but I think it's really important that we, kind of assess where we are and what can we do about it.
Well, I think we've learned a lot here in the first, we'll call it 20 minutes of our podcast here today, and one of the things that we learned was value-based isn't what we thought it was going to be. And the other point that you're bringing up is that, we are seeing drug companies make a lot of money. And we're going to see, I know, and I think you know in your heart of hearts, we're going to see an impact on our society on this over the next 10 and 20 years. I mean, look, we're going to have a lot less knee replacements, hip replacements. We're going to have a lot less cardiac events. There's direct correlation to these GLP-1s on all of those. I mean, just think about it.
Addiction.
Yeah, addiction. Big deal. I mean, listen, let me share an addiction story, okay?
Sure,
So our trade association. So one of our trade associations always had, and they've changed the venue now, but always had the event in Vegas. And I have a friend of mine who went on GLP-1s and always went to these events and took a pile of money with him, thousands of dollars. And always made a point, the first night he would stay up all night and gamble. That's what he did. And he went on these GLP-1s like 4 months before and had lost a bunch of weight. And here he is, he goes to this conference. And
don't tell me.
He sat at the table for less than an hour, and he was bored, went up to his room, and went to sleep. I mean, it had an effect on his gambling. I mean, he didn't have that addiction anymore. So there is a direct correlation to addiction and GLP-1s. I also think about like airplanes. They're going to use less fuel, right? Because you got less fat people on the planes, right? You got less weight on the plane.
It's a hope, Bob. I mean, if you still travel like I travel, it's a hope.
Yeah, I've been stuck in between two really large people
in the middle seats, right?
Yeah. No, I get it.
But, one of the things too, and this is where I will freely acknowledge my bias. I think, you talked about all this money being spent on drugs, and then there being a benefit because we're going to see these kinds of societal things. Which, by the way, that's not covered under how we pay for healthcare now. Those are just benefits that we're probably going to see happen. I think the trade industry, starting with them, has done a terrible job explaining the benefits of pharmaceuticals in the mix. Usually it is people like you and me, we go to the pharmacy to pick up a prescription and say it's not covered or it's only partially covered, and you got to shell out a couple $100. That stings. Mm-hmm. Right? And so we see as consumers these crazy prices, or someone has cancer in the family, right? And the treatments have gotten so much better, but it's $20,000. You get the bills, $20,000 for this treatment, $50,000 for this treatment, right? So we view it and we see it's just this exorbitant, cost. But if you look at it balanced against everything else, and you look at the total cost of care, or you look at in many, many cases, again, back to the example, diabetes, not just GLP-1s, diabetes treatments are getting better while we're still, having an issue with prevalence of diabetes in the United States. Improvements in cancer and survival. I mean, there's been a lot of benefits that have come, and, I think, COVID was one of those areas where we saw some benefits and we saw some challenges as well. But what I would wish for is that the associations or the companies themselves would do a better job of describing the benefits of their drugs. Instead, you watch a basketball game, you turn it on, and it's wall-to-wall drug ads with people, running, they're swimming or they're running through the fields and they're, happy, or they're picking the kid up at soccer. Whatever the scenario is, so many of these drug ads don't tell the story.
And they have names that look like my confirmation numbers for my flights.
Right.
NQ or whatever it is. I'm like, that looks like my confirmation number.
Right? It's like, what is that?
Right.
Right.
And then they always have that disclaimer at the end. And they say it really fast, and you can't really understand. And then they say, may cause death.
Right. And, your eyes are going to bleed, and, all of these different kinds of things. And so if that's your communication vehicle, if pretty much so that's where all of your money goes, is to direct-to-consumer advertising, at least this kind of effort, I just don't think that people really understand the value. And it kind of puts that whole industry in a negative light.
100%. Well, I'm going to pivot a little bit here because we could talk about this for a while. So, Darwin, through what you shared earlier, was one of the very first research groups that really, truly understood home-based care. And, today I really think healthcare is catching up. We know about hospital at home and hospices at home and home care. How do you see it all fitting together? I mean, home health, home care, hospice, hospital at home. I know someone working on, someone well beyond palliative, talking about helping people, with death and dying. I mean, where do you see this going?
So, again, my belief, my bias in all of this is that everybody should have healthcare coverage. That's kind of like a start. Whatever that looks like, these kinds of things tend to get mired in political arguments, as you know. But I'm coming from a place where I think that everybody should have access to care, especially in a country like the United States, right? In a rich country. How we go about doing that, I think the best way is with some form of integrated, we'll call it an integrated delivery system, which is a common term in our industry, but where the patient is, no matter where they are in their journey, no matter where they are in their illness, no matter where they are in their life, that is kind of under one roof, if you will. Now, that does not necessarily mean that we want 5 Kaiser Permanentes across the country that are controlling all of healthcare, right? It just means that in many, many cases, that home care, that hospice care, that rehab care, that what you're getting at the pharmacy is still very disjointed. And that's where a lot of the variation in outcomes, quality of care happens. But I don't think that it has to be through some massive, as I said, vertically integrated, 3 United Healthcares or something like that. I'm reminded by, again, this most recent interview when I asked Elliot Fisher, what's the one thing that we could do because of all the difficulties in policy prescriptions, and he said a unified EHR. Now, if you think about that, electronic health record, it's not so much, okay, well then Epic, or the big names that people know, Epic is responsible, MyChart, right? That's responsible for everything. But this comes back to the technology piece, which no one has solved yet, which is regardless is who is caring for that patient, and with all, HIPAA protections, all of that confidentiality in place, that person feels like they're being cared for by one system, even if it is multiple providers, even if it is multiple companies, even if it's a home care provider over here, which is a very, very different business than a hospital, right? Very, very different. We talked about that. And so I don't know if it's unified EHR, but it's being able to apply technology to get all of these things working together. I think that could be a game changer.
Totally.
If that now, back to the 10 years ago thing, I think maybe I would have said, or maybe I would have thought that by now that would happen. That through technology, through information exchanges or whatever, that we would have that. We're nowhere close, Bob.
Well, I can tell you here in Arizona, 10 years ago, I was on the Governor's Advisory Council on Aging. And when I first started, about 20% of the hospitals and acute and post-acute centers were connected through the Health Information Exchange, HIE, here in our state. Mm-hmm. And when I came off, it was 70%. So wow. we've done a really good job here in our state. I mean, it should be 100. I mean, God forbid you were to have an accident in Flagstaff and you would show up in the hospital there. You would hope, and you couldn't communicate, you would hope that they could pull down your records, right?
Yes.
And they'd be able to see when you last saw a doctor, what comorbidities you have, what are you dealing with, and being able to act quickly on that. So I agree with you. I mean, it's crazy how far in advance we are technologically, but we're not connected in this way.
And let me ask you, Bob, that's great. That statistic is, and it's probably, if we look today, maybe it's even higher than that, right?
I hope it's closer to 90 or 100.
But what about those home care providers? Are they dialed into that same network?
We're not.
Right?
We're not, because we call ourselves non-medical. We call ourselves non-clinical. And we really don't have that expertise to make that judgment. That's the hard thing.
But it goes back to that everything in between.
Yeah.
That home care provider, and look, I'm not here to, tout your industry, although I'm an evangelist in this area. I'm a firm believer in it. Until you get all the different pieces of the puzzle together of how someone is living their life, and I don't mean being crazy intrusive, but just this is a piece that needs to be recognized.
100%. I mean, look, if you do the math, we know about the 10,000 people turning 65 every single day, and that's going to happen by 2029. We also know that in the next 2 decades, the 65-year-old population is doubling. And we know that the 85-year-old population is going to nearly quadruple. And it is going to put major stressors onto our society and our economy. We know that there's 63 million family caregivers out there. 63 million people that are making a sacrifice to be there for
That's
our loved
one. Incredible.
It really is. And caregiving takes many, many forms. Going to the pharmacy and grocery store, you're a caregiver. Helping someone get up in the morning or picking them up and giving them a ride, you're a caregiver. These are family members that are doing this hard work every day and making lots of sacrifices. I wanted to ask you, where do you see the role of family caregivers in the future? And do you think healthcare organizations give them a lot of credit? I mean, for me, when you see that 1/3 of our population is solo aging, 65 and older, solo aging, and that number is going to creep up to almost 50% by 2050. How do we do this? And I think, and this is just my opinion,
Sure.
we have to engage these family caregivers. We've got to give them the tools. We've got to give them the knowledge base. We've got to give them access to ways to be able to care for their loved ones. We could sit here and talk about this till the cows come home. I mean, literally, when you and I were in school, we took woodshop and home economics. Home economics, where we learned how to cook. We should
cook an egg.
We should be able to do this for the kids today and teach them how to care. Give them CNA training so that they have these soft skills that they can use with their own family members. And I really believe, Johnny Mac, that we're going to see us go back to the way we lived the last century, where you're going to have family units living in the same neighborhood. You're going to have clusters there, so you're going to have children, grandchildren, nieces, and nephews, because there aren't going to be enough people out there to do the care. And by the way, I mean, a lot of people are working from home.
Yeah.
So, we don't have to travel away from our family unit to get a job. We can stay in the same neighborhood and we can raise our family. So, those are the things I think about in terms of how to solve for this. But I really believe that the family caregivers are the source of relief and the source that will help enable these people to stay independent as long as possible. So how do we encourage these healthcare organizations and healthcare in general to see that light?
Well, what I would wonder is, or what I am wondering is there a role for the healthcare organization? We can name those in town, right? I mean, we've got Banner, we've got Honor, we've got Mayo, we've got
Dignity,
Valleywise, right? There are a lot of providers here in town. What is the incentive for them to do that? Well, one of the incentives is, using your recent surgery, what is it the one thing that they want to avoid happening after your surgery? I mean, if we're being...
readmission.
Right. They don't want you coming back.
Because they get dinged for that.
They get penalized. Yeah. And regardless of whether it's a kind of private pay or if it's Medicare, that's a no-no. Every one of these organizations is looking at readmission rates. And so that's an incentive. That's a positive incentive, or maybe the avoidance of the penalty. But it's really the same thing. Mm-hmm. But I wonder, because I know, Bob, you and I, whether it was on a program like this or if it was over a beer, I mean, we've had this conversation multiple times about the role of the family and where we've gone over the years, and people, they turn a certain age, they go off to school maybe, or they move, and you have this everybody's spread out everywhere. I can say for a fact, I've got one kid in North Carolina, I've got one in California, I've got one in Oregon, and I've got one here. My extended family, I have people in Chicago, I have people in New York, I have people in Florida, I have people in Kentucky, I have people in Ohio. We're all spread apart, right? But what I'm wondering is, with other societal changes, cost of housing, people working from home, are there structural changes? Boy, we're getting out of health futures, or maybe this is futures, right?
This is futures.
Right?
Come on.
Are the changes that are kind of happening in our society, conducive to that family unit being more cohesive, where people will be able to care? Because I know we've talked about this before. There are certain, ethnicities
100%.
or where that's kind of part of their culture, and
it's a big part of their culture.
And certain ones, I'm sure at one point in time, my Italian culture, I'm sure that was very, very strong. Not so much anymore, but other cultures, yes. But are there, things happening in society that will keep people closer in their communities, working in their communities, because a lot of people working virtually, people staying at home longer? I have no statistics on this. Maybe you do, but I know it feels like, to me, multi-generational housing has been making a comeback over the years.
It's interesting. My wife Susie and I, we like go to Hawaii. So in 22, we went back to Hawaii, and the resort that we were staying at is our timeshare. There's 7 restaurants there. 7 restaurants, and only 3 of them were open, and they were open for limited hours with limited menus. And I remember going up to the bartender. You ready for this? And I said to the bartenders know everything. They really do.
Yeah.
So I said to the bartender, I said, hey, what gives with these restaurants? I mean, Susie and I like this restaurant. It's not open. This one's only open for limited hours. He goes, we can't find staff. I said, what do you mean you can't find staff? He says, well, the island was closed for nearly 2 years because of COVID. And I said, yeah. And I said, but you have a lot of people here. And he said, most of them were from the mainland. Most of them were young adults that came across from the mainland, and wanted to live the Maui lifestyle. And when the governor was closing down the island, they left to go home. And he says, as a matter of fact, some of them are my friends. And I said, well, have you called them? Are they coming back? And he said, no. And I asked him why. And he didn't know I was in healthcare. He said to me, he goes, they discovered that they were needed more at home with their family members, their parents.
Wow.
And to me, that's what's happening right now across the world, and certainly in our country. And I don't know about you, but my contemporaries and I are talking about our mothers and our fathers. I mean, mine are both gone now, but they're talking about them and how they're caring for them and what's going on with them. And, you know, it's indicative of what's happening. And I really believe that part of the solve is bringing family members together. And I think that's the only resource that we got. We don't have enough people behind us. In order to sustain our population of 345 million Americans,
Yes.
every child-rearing female needs to have 2.1 kids, and we are at 1.58 and declining. You did your job. You got 4?
Yeah.
I got 3. So we're good.
We're good.
We're good.
We're above average.
But we need the others to do their part.
Yeah.
You know, I want to pivot a little bit and talk a little bit about what you do at Darwin Research Group. You've had a chance, you know, through healthcare rounds. You've interviewed over 200 healthcare executives, and they've had various positions, whether they've been in hospitals, value-based care, primary care, specialty pharmacy, rural health, policy, and innovation. So you've talked to some of the smartest people in healthcare. Is there any one that you can just say, I mean, I'm sure many of them, but is there any one person that just like wowed you and changed your thinking about healthcare?
So I don't know that there's necessarily any one in particular. What I would say is, when my first company, years and years ago, I had a medical education company. And I sold that to go work on a PhD at Dartmouth in their kind of integrated program in healthcare. And the first thing, which kind of goes back to what we first started talking about, Bob, that was really, it wasn't any one person, but was kind of an aha thing for me, was this notion that spending more doesn't necessarily get you better. Because we in this country, and I've taught this concept at the undergrad level, I talk about this with our clients, I've given presentations on this whole concept. We're so attuned to this notion of equating price with value. And I'll put up on the screen, you know, pictures of, you know, Maseratis and Ferraris, and, you know, especially the students are like, oh yeah, those are awesome. That's like the best of the best. And then I'll put up a Toyota Camry, right? And, you know, the reality is maybe for 95% of what the average person needs to do, maybe that Toyota Camry is a much, much better value, much better buy, right? Okay. Not going to be in the shop as much. When it does need to be fixed, doesn't cost as much. But there is just this overwhelming sentiment, and that is absolutely not true with healthcare. There's so much evidence that shows variations in how much you spend on something across the country and whether or not you're going to get the same kind of result. So it just doesn't equate. And I would say, if I can pick on one interview, this is going to sound like really microcosm, very small issue, but I still think about this today, and this was years ago. I had a guy on, I want to say his name was Christopher Robertson. I may have to change that, but I think that's right.
Not from like Winnie and the Pooh?
No, that's Christopher Robbins.
Oh, it was close.
All right, Pooh. Oh no, that's Eeyore. But if I remember too, he was either a lawyer or an economist or both. But he talked about this thing with copays and just argued vociferously that the idea that you go to a pharmacy and you pay something for your drug, or you go to the hospital to have a procedure done, you have to pay something out of pocket, that it's arbitrary, that it doesn't really, the idea is, okay, you're paying something so you have some skin in the game, right? So, I mean, there's fancy words for this around moral hazard and things in insurance. And I think he had a pretty good point, that we have this notion of copays in medicine that really doesn't change any of the outcomes, and all it does is take money out of people's pockets. And so it kind of gets back to the financing. I don't know if that's like the most sexy answer you could get, Bob, but I still think about that today because it's so ingrained in our insurance system, and it's kind of like, why? You know, what is the purpose of it?
So you're in the data business, and you get
Yes.
a chance to talk to a lot of leaders. You know, how do great leaders make decisions when the data isn't quite perfect?
I think they do every day. You know, I mean, I certainly there are more data-driven leaders, and nowadays with better technologies, but AI and all of this, we're getting better and better data, which can give you better decisions. But I really think the best leaders that I've talked to have some sort of, I don't know if this is the right word, Bob, but like moral compass, some kind of internal way that they're viewing their organization, their mission, their world, and that's driving their decisions more than anything else. And I don't think it's just a matter of gut, because you also need experience with that. But I think it's the ones that really are grounded in sort of, again, I'll use that term, moral compass, to move their organizations forward, that maybe in the face of certain data, they've got to ignore it. Or they have to say, regardless of what this pie chart is telling me, I know that this is what's right for my organization, and this is the direction that I'm heading. And that can be very difficult.
It can be.
Right?
Especially when the data doesn't necessarily support it. I mean, let's face it. I mean, some of these leaders are entrepreneurs, are risk takers.
Mm-hmm.
And if the data doesn't corroborate with what they're feeling about, sometimes they feel like they're all alone, but a lot of it, they feel right here, right? They feel experience matters, and my gut tells me we need to go this way.
Well, it's interesting because, and maybe we will get to AI, or I don't know, but we've kind of talked about it, but any use that you've had with AI, ChatGPT, Claude, right, all these different, Gemini, doesn't it sound really good when you're getting a recommendation? Doesn't it sound very logical when you're asking it questions? And so, but then there's the human judgment component, which gets back to the leadership. And I still think, call it gut, call it experience, call it a combination.
And execution's everything, right? I mean, if you can have a great plan, but if you can't execute it,
absolutely,
then you're going to fail. I want to take our conversation to the next level, all right? And then we're going to get to a little more personal. Do I need to be worried, Bob? No, look, looking ahead.
Yes.
So imagine we're sitting here 10 years from now. So now it is 2036. Can you imagine that? 2036. What headlines do you hope that we're going to be talking about in 2036?
If I had my wish list, and I'm thinking in terms of healthcare, I think number one, that this whole notion of whether or not that people get health care is no longer an issue. That the access problem that is still endemic here in this country, that's gone. But secondly, I kind of joke about this, but it's half joking. I'm always afraid that it's either cancer or Alzheimer's that's going to get me. Mm-hmm. I say half joking, not joking, really. That in 10 years, we will have, maybe through a vaccine in some sorts with certain types of cancers,
and even Alzheimer's,
that we have made substantial progress to the point where it's a disease to be managed. I'm old enough, although I was really, really young at the time in my career, but I'm old enough to remember when you got an HIV positive diagnosis, that was a death sentence.
I remember that.
You remember Magic Johnson? He's still around.
Yeah.
He's the first high-profile person. Now, you take a pill once a day or twice a day, and and it's managed. So what seemed to be insurmountable at the time with HIV and AIDS, we solved that problem. So if I'm looking backwards, I'm saying we've solved the access issue, and we've made substantial headway, if not come up with a, dare I say, cure for the two biggest issues that I am concerned with personally, which is cancer and Alzheimer's. Now, I will say the first thing we probably need to fix, and this is borne out in my most recent interviews, I had Claude help me out, pull some notes from those interviews, is cardiovascular disease. Yeah. It's the big one. If we could make a dent, and so again, 10 years out, looking backwards, and I think in order to make a dent in that, that's not just drugs. That goes back to what you've been saying. That's the accountability, that's the lifestyle, that's the things that we absolutely have control over. You know, there's, with cancer and smoking, there's some things that you have that direct line, right, relationship. There's a lot of cancer that is not explained by those kinds of things, that is just purely genetic, right?
Or environmental.
Or environmental too. And
especially the blood cancers.
Absolutely. So there is that, but cardiovascular disease. So I guess my hope or my vision, if they could be one and the same, is that we've been able to tackle those issues and successfully have solutions for them.
All right, so now we get to the part where we have some fun. All right, so
okay. This has been fun, though, Bob.
I know.
This is great. I could go for another hour.
And I'll probably have a couple of questions to leave you with, but I want to have fun with this, because this way our audience gets to know a little bit more about John Marchica,
okay,
a.k.a. Johnny Mac.
Fair enough.
All right, so coffee or tea?
Coffee.
Rapid fire.
Coffee.
Morning person or night owl?
Morning.
Book you've recommended most?
Ooh, wow. There's so many. Current book?
Yeah. Give me a current one.
I'm going to give one from the past. Stephen Johnson's Emergence.
One healthcare leader everyone should follow?
Eric Topol.
Favorite podcast guest?
Favorite podcast guest that I've had? Can I decline on that one? I still have to get more guests, Bob.
Okay.
I have a great answer. You, Mr. Bob Roth.
I was waiting for you to say that.
I was going to say you, Mr. Bob.
Can you believe you'd not say that?
In fact, let's set the record straight. You were one of my earliest guests, number one, and sat at the top in terms of downloads for a very, very long time, and it's still a highly sought episode. Yeah.
I think I did the first one like in 2016, 17. You did it in 2018.
2018.
So 2018.
So, but you were maybe second or third. You were right there.
Thank you. Most underrated innovation in healthcare?
Most underrated innovation in healthcare. Pharmaceutical packaging.
AI. Are you excited or cautious?
Very cautious.
One word that describes or defines great leadership.
Empathy.
One healthcare myth you'd like to eliminate.
More is better.
One thing most people don't know about Johnny Mac.
That I'm a total music snob. That I love. I love music. I've got very strong opinions on the kind of music that I listen to.
How many guitars do you have?
I thought about this the other day, and it's an even dozen.
You have dozens.
It's an even dozen.
Wow.
Yeah.
That's
after selling off a few. And Rhonda's getting on me to be like, "Come on, you're taking over the house with these things." So
it's larger than the collection I remember. So you've added a few.
Yeah.
That's great. Favorite city besides Scottsdale?
Chicago.
What's your favorite way to recharge?
With my guitar or piano.
One prediction for healthcare in 2036.
We will have solved the access problem.
Best career advice you've ever received?
From my mentor when I was leaving Abbott to go start my own company. This is the dumbest idea that you've ever had.
That challenged you. You were like,
right.
Okay, come on, right?
That's right.
I know you.
I hope you're listening now. I won't mention your name.
If you could have dinner with one historical figure, who would that be?
A lot of clever answers to this, but if I'm honest, it's Steve Jobs.
Nice. As someone who has spent years turning data into strategy, what's the difference between having information and having wisdom?
I would say experience. That's not a very clever answer, Bob, but it's experience. You need to know what to do with data, and that's another challenge with AI. I think it's not always pointing people in the right direction.
John, I always appreciate having you and being around you. Your opinions are always grounded in great research. And
thank you, Bob.
I admire you for the work you do. It's something I could never do, but you do it, and you do it very, very well. In a world where everyone has an opinion about healthcare, you've built a career helping organizations make decisions better based on evidence. I really appreciate you joining me here at Health Futures, and I can't let another 10 years go by without having you here in the studio. It's been really great having you back, and I want to just ask as we get ready to close, is there a question I haven't asked? Is there a thought you want to leave our listeners before we say goodbye?
Yeah, I do have a thought. It may not be what you expect. But thank you for having me first.
It's great having you.
Appreciate it. I don't think that people can really appreciate on the other side of this microphone or on the other side of the camera what a fabulous leader that you are. And you have been from the start, from the very first meeting, as our friendship has grown. I don't tell you this enough. In fact, I may have never said this, but you are truly an inspirational leader in the work that you do, in the way that you've run your company. And it's not just me who says that. I've got plenty of validation from other people who would say the same thing. So in my eyes, you epitomize that thoughtful, empathetic, caring leader, whether it's people in your organization or the people that you care for. And I've admired that all these years and even to this day. So thank you, Bob.
Johnny Mack, I appreciate it. Thank you. Thank you for joining me on Health Futures.
Thanks.
Thank you, our listeners and our viewers, for joining Health Futures. Make it a great day. We'll be back next week. Thank you.
Thanks for listening to Health Futures, Taking Stock in You. I'm Bob Roth, reminding you that living well isn't just about years, it's about the quality of life and connections. Follow and share the show, and join us next time for more on how to live a longer, healthier, and happier life.